Welcome. Thank you for joining us. We're here today to talk about menopause. And here today with me, I have two of our nurse practitioners. I'm going to ask them to introduce themselves.
Hi, I'm Maiah. I'm a nurse practitioner and nurse midwife at Valley Women's Healthcare.
And I'm Darcy, also a nurse practitioner and nurse midwife at Valley Women's Healthcare.
Great. Glad you could be here. And let's start off with our first topic. So can you tell us what the difference is between perimenopause and menopause, and then what the typical ages are that people start experiencing this?
Yeah, so the technical definition of menopause is when a woman has had their final menstrual period. We don't know when that is until hindsight, when we look back in the rearview mirror. And so once a woman has officially not had a period for 12 months, then considered postmenopausal. Prior to that is perimenopause, or the transition time. And that on average lasts 4 to 7 years, but for some women it's a whole decade before. So, and the typical age of menopause in the US is between ages 51 and 52. However, with that said, some women start having those symptoms again in their 40s. And if someone has gone a whole year without a period before the age of 45, especially if they're younger than age 40, then that is a different kind of topic that we're not covering today. It could be a sign of premature menopause or primary ovarian insufficiency or even polycystic ovarian syndrome, PCOS. I would also like to add, though, that when we use the term women, that is a very gender-specific term. Not all people going through menopause identify as women. So really, when we say women, really meaning anyone with ovaries. Everyone that has ovaries at some point in their life will go through menopause as the ovaries come to the end of their reproductive life.
So let's talk about the typical and less typical symptoms of perimenopause. So like, for example, I had a lot of hot flashes, but I was surprised when I found out that my friend had 0 hot flashes.
Typical signs that I think bring people into the clinic and bring people to see one of our providers or us is a lot of the times hot flashes. I'd say the hallmark sign that we see is a lot of really irregular periods. Sometimes people come in and they've had normal periods for most of their life, and then all of a sudden they're noticing either they're skipping months or they become heavier and longer, or the opposite, and they become shorter, and then all of a sudden they realize that they've reached maybe the end of their cycle. And kind of what Darcy said, we recognize that diagnosis retroactively. So I'd say that hot flashes, night sweats, which are hot flashes during the night, they keep people up at night. Irregular periods, those are 3 of the really big ones. Other ones that are typical and maybe we don't hear as much when people come in are brain fog, insomnia. Another typical one that I actually want to touch on is vaginal dryness, maybe new pain during sex, changes in the vaginal flora, maybe discharge, that sort of thing too. So those are some typical ones. Touching on a little bit of more non-typical ones too, aches, joint pains, muscle aches, those types of things too. Kind of just a caveat when saying typical and non-typical is, people, they might be more typical for people might be experiencing them, but it's not the thing that typically brings them into the clinic to talk to someone about it. And just touching on something that we'll probably talk a little bit more about later on in the video is when people go 12 months without a period, without any vaginal bleeding, let's say they go maybe a year or 2 without it, and then they experience some bleeding again. That would be something to see a provider about. That would be something we want to investigate further as to why that's happening. I wouldn't say that's typical or less typical, but that's something that sometimes does happen in menopause that we want to investigate further.
So let's look at the topic of racial and ethnic groups, if there's any differences in how they experience menopause.
Yeah, and we know that women of color tend to have the vasomotor symptoms, those hot flashes and night sweats, occur more frequently and have a longer duration. So for those women, symptoms may last for up to a decade or even more.
I think it's important too to kind of touch on different racial, ethnic, social groups as well, and how, first of all, they view menopause and aging and how different that is culturally, whether that is, Black, Latina, Asian populations, and then, of course, even white populations as well. So that does affect the transition to menopause and what menopause looks like. It's just culturally how that's viewed. And then it's important as providers, especially, to kind of consider more in the back of our mind the racial, ethnic trauma in the medical field and how long-lasting that was for people of color in America and how we treat people of color in America.
Another topic is mental and emotional health. So, for example, in my community of friends, and we're all going through menopause at the same time, we all notice that we seem to have an increase in anxiety symptoms.
Yeah, I think that we do know, unfortunately, that there is an increase of mood disorders such as depression or anxiety during this perimenopause and menopausal transition in life. It's unfortunately often underdiagnosed and undertreated. I think that culture plays a large role in that as well, kind of touching on the differences in culture and how we view menopause and aging is a lot of the times based on the stories that our moms, sisters, aunts, grandmas tell us about aging and menopause and what they went through in that sense.
Yeah, that's a really good point. For example, we know too that Japanese women tend to report less symptoms of menopause, and that is probably attributed to a cultural difference because they view aging more positively. I like to say that an aging body is a changing body. And so, menopause isn't all doom and gloom. A lot of women at this stage of life feel more confident, they're more self-aware, they know who they are and what they want, we're wiser. And some women tend to be more financially stable and maybe they're done raising children, so they have a little bit more freedom. So this stage of life could also be looked at as the menopause zest.
So how can someone know the difference between having perimenopause symptoms or perhaps other medical conditions?
Yeah, that is a great question. The first obvious answer is age. So for most women, they typically start having symptoms around age 45. And again, if symptoms, you're younger than 45 and definitely younger than 40, you'd want to get evaluated by your primary care provider for something like the premature menopause or primary ovarian insufficiency or PCOS. But going back to if symptoms start around age 45 and are even lasting, 2 years beyond that final menstrual period. After that, symptoms tend to start to get better with time as those ovaries finally shut down and they're no longer producing hormones. But those constellation of symptoms, if looked at individually, could be underlying causes. So that's why it's important to do some routine screening.
And that routine screening can look for other things such as iron deficiency anemia, sleep apnea, anxiety and depression, thyroid dysfunction, whether your thyroid is overactive or underactive, diabetes, and many other things too.
Yeah, and I think it's also important too to remember that, medical diagnoses don't happen in a vacuum. There's life stressors, so big life events too can also contribute to how we feel emotionally and physically. I'd also like to just bring up the topic of checking hormones, because a lot of women come in and want their hormones checked. There are rare instances where we actually need to know what an estrogen and progesterone level is in the bloodstream. Again, going back to those premature menopause, that would be a reason to do it. But otherwise, we don't really need to know what those levels of hormones are because we would treat based on your symptoms, not the level of hormone in your blood.
So we've talked about symptoms of menopause, and now let's talk a bit about managing it. What are the lifestyle things that you can do? What are medical treatments? And just talking a bit about lifestyle, I found that strength training has been really helpful for me with some of the muscle and joint pain that I experienced. But what do you do when you give guidelines?
Yeah, I love that you bring up lifestyle as something that we typically ask about first. So when people come to me and talk to me about their symptoms, the first thing I ask is about their nutrition, exercise, especially strength training, and that sort of thing too, finding ways to move your body in ways that you enjoy. And then I talk about if you are recognizing triggers. So, some people might say, oh, if I drink alcohol, my hot flashes get worse, or other triggers that you might recognize as well. And then other things as well too I'll ask about that are just lifestyle things. Do you smoke tobacco?
Yeah, once we've asked about lifestyle modifications, then we can also talk about medical treatments in the form of medications. And there is menopause hormone therapy, but I will say that not everybody needs it. We don't have to treat symptoms unless they are truly bothersome and affecting quality of life. So in terms of hormone therapy. We know for healthy individuals, generally speaking, that starting hormones under the age of 60 and within 10 years of their last or final menstrual period is considered generally safe. And we know that hormone therapy works best to treat hot flashes and night sweats, depression, and as a preventative for women who are of high risk of developing osteoporosis. There are some very specific contraindications to using hormone therapy. For example, women who've had breast cancer that's estrogen receptive, we don't use hormone therapy on them. I will say that a family history of breast cancer does not necessarily exclude somebody from using hormones. A lot of women are familiar with the Women Health Initiative study that came out in the early 2000s. And after it was released, the use of hormones really plummeted because there was an association between hormone use and breast cancer. We are more than 20 years beyond that study now. We have lots of great information and more data, including we have more and different hormones that we can use, different ways of getting those hormones into the body, different doses, so they have a better safety profile. For some women, during the transition, hormonal birth control can be an option, even if they don't technically need it as birth control. So, for example, some women have had a hysterectomy, but maybe their ovaries are still in place. And when we're menstruating, it's normal for our hormone levels to vary throughout the month. That's what instigates us to ovulate and to have a period. For women during the transition, those hormone levels are varied very widely, and that's when having more irregular periods and erratic mood swings can happen. There are also non-hormonal medications that we can use to treat menopause symptoms, including SSRIs, the selective serotonin reuptake inhibitors, gabapentin, and a newer medication that was developed specifically for the treatment of hot flashes and night sweats, which is fezolinetant. So there are other non-medical ways to help treat menopause symptoms, including cognitive behavioral therapy, which is a psychological therapy that helps us to change the way we think and our patterns of behavior, which that can be great for those hot flashes, night sweats, insomnia, depression, and even decreased libido.
So speaking of libido, let's talk about that. Do you have treatments for being able to manage a decrease in libido or other changes with your sex life?
Even though women might not have that spontaneous drive to want to have sex, they can oftentimes still have a very fulfilling, enjoyable, happy, healthy sex life. Maybe they don't want to initiate it, but a lot of women are still able to achieve orgasm and still enjoy sex. But for those that it's distressing that they don't have a sex drive, there are some medications that are non-hormonal, and those have been studied in perimenopausal women to be effective. It would be considered off-label use for postmenopausal women. There's also off-label use of testosterone gel. Testosterone levels can be too high, so this would be a case where we would want to monitor hormone levels because if there's too much testosterone, it can cause some physiological changes that are not reversible. If the decreased desire for sex is because it hurts to have sex, it's physically painful, then that's a different topic.
So are there long-term health effects that are associated with menopause?
Yes. Going back to discomfort with sex, we know that there are vaginal and vulvar changes with menopause that usually just get worse with time, even well beyond the transition. The lack of estrogen causes more vaginal dryness, which again can cause more discomfort with sex. The vagina is not as flexible or as elastic as it used to be. Decreased blood flow to the blood vessels also make the cells in the tissue a little less resilient. So even women who aren't having sex still say it just doesn't feel right down there. And so it's important that we treat for that. Vaginal estrogen is considered very safe. There really isn't anybody who can't use it because it's localized. You're not absorbing it systemically throughout the body. And it just helps to kind of revitalize the skin and the tissue down there. What we also know is that it also helps with bladder health. So a lot of urologists are even excited about vaginal estrogen because long-term, we know that women are also at more risk for urinary tract infections and bladder infections. And so vaginal estrogen can help prevent that.
Yeah, I think Darcy brings up a good point of long-term health effects are oftentimes due to the depletion of estrogen. So another big part of that is something that you brought up previously, which is strength training helps make your bones feel better, or joint and muscle aches feel better and less severe. And we talk about long-term health impacts as far as osteoporosis or bone loss throughout menopause and postmenopause. So important aspects of osteoporosis and prevention of that is not only screening at a certain age, but also increasing vitamin D and calcium supplementation. And we really do encourage strength training in order to decrease those fractures and bone breaks and that sort of thing too. Other changes are body composition. People's bodies look different. People's bodies hold on to, adipose tissue or fat tissue in different places post-menopause. So they look different than they did as we all do as we age, look different. So that's a big change too that I hear a lot about. Skin changes as well too.
Yeah, and just being mindful too that we know cardiovascular disease is the number one killer of women. So that's where really these lifestyle modifications will be beneficial, even beyond the transition and well into the postmenopausal years. So it's important to get screened for things like your blood pressure, cholesterol, doing diabetes screening, no smoking, good nutrition, and lots of exercise.
So for those who are experiencing perimenopause, are there times when you should seek care from a healthcare professional?
Really good question as well. And I think a lot of my answer is going to echo everything that we talked about throughout this talk, which is really when you just don't feel like yourself anymore. If you're experiencing changes as you're going through the perimenopause and menopause transition that are uncomfortable, affecting your quality of life, and you just want to learn more. I've had people come in and, I always ask, what do you want to get out of this visit and how can I help you? And their answer is just, I want to learn more. I want to learn about the changes going through my body and, how to be my healthiest self and feel better. And I think that that's kind of what Darcy kind of talked a little bit about too, is the beauty of aging. And a lot of the times we live a third of our life in menopause and postmenopause. And so, how do we live that third of our life? It's maybe the best third of your life or, just something that you want to see your provider about just to learn more and talk about. So something that we also chatted a little bit about too is who do you see during this time? If you already have a relationship with an OBGYN, a gynecologist, a nurse practitioner, a nurse midwife, those are all people who can really help with these transitions, these symptoms, talking more about it, doing more education. If you don't have an established clinician in your life under those specialties, then I recommend seeing a primary care provider first. They can screen for things, and then recommend seeing a specialized person who knows a lot about menopause and can talk more about it.
So we covered a lot of information today about menopause, which is great because a lot of this information has not been available to women and they kind of had to suffer on their own to experience this. And so moving forward, where can people go if they want to learn more information?
Yeah, I always recommend the North American Menopause Society website, menopause.org. They've got a lot of great initial basic information that's user-friendly.
And people are always more than welcome to come see us at Valley Women's Healthcare.
Well, thank you, Maiah and Darcy, for answering the questions today. And for those of you watching, if you want to learn more, we'll have links to those websites and we encourage you to link them.